very warm welcome to today's discussion. I just want to tell you that many of my very curious students have asked a question that how to differentiate between aminoglycosides and macrolides which share the same suffix mycin. What they're really asking that many of the aminoglycoside at the end of their name they have mycin. In the same way, most of the macrolide also at the end of their name they have mycin. So how to differentiate if those aminoglycoside which are having mycin at the end and those macrolide which are having mycin in the end, if they are put together, how do you differentiate between them, right? Let me tell you, this is the basic concept we are going to talk today. As we know that the first aminoglycoside which was discovered, streptomycin, that was streptomycin, and after that then there are other important aminoglycosides, for example tobramycin, right? Streptomycin was the very first drug which was successfully used in treatment of the tuberculosis, right? Then tobramycin. About tobramycin, you need to remember that those patients with cystic fibrosis, when they have infections in their lungs, we can use tobramycin in inhalational form also, and many other uses, of course. So there's streptomycin, there's tobramycin, there's kanamycin, and of course then there is neomycin, and all of them are having in the end mycin, right? Now the question is, number one, why these aminoglycosides are having mycin at the end, and number two, how to differentiate these aminoglycosides with the mycin as a suffix from the macrolides which are having mycin. As we know, the macrolide drugs which are having mycin at the end, classically the first one to be discovered, the prototype was erythromycin. Okay, I will just write mycin everywhere. Erythromycin, then after that, molecular modification of erythromycin produced better drugs. I will tell you in what way better, right? But prototype drug and the first one to be discovered was erythromycin, and after that then we came up with clarithromycin, and then we came with azithromycin, and one of the more drug which is used, that is roxymycin. Roxythromycin. Now you look at it. Erythro suffix at the end is mycin. As there was streptomycin, tobramycin, kanamycin, neomycin. Here you see erythromycin, clarithromycin, right? Azithromycin and roxythromycin. Now, how do you differentiate them? For especially the medical students who are in third year or who are newly studying the antibiotic, remember, even though mycin is common suffix on both sides, but there is something very special which has been added to the macrolide group, and that is thro. Now it is erythromycin. So if the word at the end is not mycin, thromycin, you must think of that it is macrolide, right? And again, clary is, yes, from here, what is this? Thromycin, azithromycin, roxythromycin. So a very simple thing is that aminoglycosides have a suffix at the end, mycin, which I have written on the board, right? These aminoglycosides, and these macrolides, even though have mycin as the suffix, but they have something just before that, that is throw. So macrolides can be recognized and differentiated from aminoglycosides, that they are not having only mycin, but just before the mycin they are having throw. So thromycin, right? So if I see XYZ drug and mycin, look, if I say there is XYZ drug ending up with mycin, and I say that it is either aminoglycoside or macrolide, tell me what it is. So it must be, yes, that must be aminoglycoside. But if I say there is another drug that is XYZ ending up with thromycin, then can it be aminoglycoside? No, it is macrolide, right? And here I would love to mention one more point. The one more point is, all of these drugs, these are derived from soil bacteria called actinomycetes, these soil bacteria actinomycetes. Now, let me tell you something very interesting about these soil bacteria or environmental bacteria, that actinomycetes are the source of most of the antibiotics which we are using presently. Most of the natural antibiotics which are derived, they are derived from actinomycetes and its subgroups, subgenus. 70 to 80% of the antibiotics or their derivatives, because actinomycetes are an inexhaustible source of bioactive products, including many drugs which we use today. For example, from actinomycetes we derive, yes, antibacterial drugs. We even derive antiviral drugs. We derive antifungal drug. From this we derive immunosuppressive drugs, right? Even some of the anti-cancer drugs. So actinomycetes, this type of soil bacteria, is a huge blessing for humanity, that they are an inexhaustible source of different bioactive compounds which can be derived from actinomycetes, and many of them are being used as medicinal drugs, right? Now, actually, from where streptomycin, tobramycin, kanamycin, neomycin and similar aminoglycosides are derived? They are derived from, okay, I just want to make it, it's very proud because of its services. Yes. Now, one genus, that is Streptomyces genus, right? This Streptomyces genus, which is a subtype of actinomycetes, you know, this is responsible for all these aminoglycosides which end up with mycin, which are ending up with mycin, right? And again, macrolides, erythromycin was also originally discovered and isolated from another genus of actinomycetes, and the new name of that genus is, yes, the new name of that genus is Saccharopolyspora erythrae. polyspora erythrai genus. Now, this genus is actually responsible to produce erythromycin, and then with different chemical modifications of erythromycin, we end up with better drugs like clarithromycin, azithromycin, and even some other roxithromycin. I want to say one thing here. The most common macrolide which is being used in the world is presently erythromycin. Why? I will tell you in few minutes. I will go back there and explain it to you. But let's come back, because one of the students also asked me that some of the aminoglycosides, they don't end up at mycin, they end up at the mycin. Actually, for this purpose, for example, they end up not at mycin, right? Some of the aminoglycosides, they end up with mycin. Why is so? For example, these are which one? Yes. These are also aminoglycosides, I'm going to write, but they don't end up at mycin, they end up at mycin. For example, there is gentamicin. Then there is natalmicin. And then there is, yes, what you are saying? Ciso. Cicomycin. And we can also put plazomicin. Now question is, these are aminoglycosides ending up with mycin. These are also aminoglycosides which are ending up with mycin. Why is so? Answer is that it is about their source. That is about their source. As I told you, aminoglycosides which end up with mycin, they are basically derived from a genus Streptomyces genus. But those aminoglycosides which end up not with mycin but end up with mycin, they are derived with a different genus of actinomycetes, and that different genus of streptomycetes is called micromonospora. Micromonospora genus, right? So this genus is responsible for this genus is the source of gentamicin, natalmicin, cicomycin, or plazomicin. Gentamicin was the original to be discovered, others are derivatives of that, right? Now, let's have very few words about erythromycin, clarithromycin, and azithromycin. As we know, the first drug which was discovered was, macrolide which was discovered was erythromycin. Erythromycin. But then what got popular? Clarithromycin. And then what got most popular? Azithromycin. Actually, erythromycin was approved in 1952. Then clarithromycin was approved around 1991. And then azithromycin was approved around 1992. Actually, I don't know, mother drug or father drug or parent drug, whatever its gender is, erythromycin was the original drug. Then chemical modification in its structure resulted in formation of clarithromycin, and further modification resulted in formation of azithromycin. Now, The major question here I want to answer is why all over the world the use of parent compound erythromycin is progressively decreasing, and why all over the world the use of erythromycin is progressively increasing, right? The answer lies in actually all of them work with the same mechanism of action. They inhibit the protein synthesis by acting on the inhibiting the function of 50S ribosome. Even though the mechanism of action is same, but they have different pharmacokinetics, they have different side effect profile, and they have different propensity for drug to drug interaction. Let's start with it. Number one, when we altered erythromycin chemically and resulted into clarithromycin and azithromycin, from this position as you move down, pharmacokinetics favorably change. Even though erythromycin can be taken per orum, clarithromycin can also be taken per orum, and azithromycin can also be taken per orum, but there is difference. You know, erythromycin has a trouble. It is when you take it orally, if it is not enteric coated, it will be significantly destroyed by gastric acid. Secondly, it also produces a lot of GIT irritation, due to which, because before from GIT it gets absorbed, lot of it is destroyed. So its bioavailability is less. And not only bioavailability is less, but it's of course the result is half-life is less. Right? The result will be that when half-life is less, you have to give multiple doses per day. So when we prescribe erythromycin, we have to use it every 6 hourly or 8 hourly. It means it may be TDS or QID, right? More frequent dosing, which of course reduces the what? Which of course reduces the compliance. Secondly, as I told you, that but as you move down, these drugs are acid stable. So they don't need to be enterically coated. And as they are not destroyed by within the GIT by the acid, so their absorption is better. So bioavailability is better. Then what happens? Serum levels go up. Half-life is better. Their tissue penetration is better. Even clarithromycin and azithromycin better enter into bacteria. And azithromycin in good concentration enters even in macrophages if some bacteria are there. So what does it mean? It means that as clarithromycin and azithromycin have longer half-life and better penetration, so we need to give less frequent doses. For example, clarithromycin, rather than TDS, we can do 12 hourly, BD, right? And azithromycin is having even longer half-life, even we have extended formulation. Due to that reason, we can give it once a day. So this was the first thing which I wanted to impress on my students' mind, right? That why erythromycin is becoming less popular and why clarithromycin and even azithromycin especially is becoming very popular. There are many reasons. One reason I told you that erythromycin is not acid stable. So bioavailability is less. Then of course, what is this? Half-life is less, tissue penetration is less, cellular penetration is less, right? And we need to give more frequent doses, which translate into less tolerability and less compliance. Erythromycin has more side effects. As you move down, right, even side effects decrease, right? As clarithromycin, azithromycin, I told you, they are acid stable. So they are better absorbed, they better bioavailability, better half-life, and better penetration in the tissues, better penetration and distribution not only into whole body, but even in the cells, even in bacteria, even in macrophages, right? So this is one thing that we have to do it 3 to 4 times a day. This we can give it twice a day, and here the dosing can be once in a day. Of course, it's a significant advantage. Second thing is, not only about its pharmacokinetics, there's another thing, and that is about spectrum of activity. You know, erythromycin mainly act on gram-positive bacteria, right? Aerobic gram-positive bacteria. But clarithromycin and azithromycin, they have broader spectrum of activity. I will not go into detail of this thing in this lecture, right? Because this lecture is really only I intended in the beginning to teach that how to differentiate between those aminoglycoside and macrolide which have a suffix, share the suffix mycin. But I thought just give few words about this. Now, let me come back. So what I was talking about, that as compared to erythromycin, clarithromycin has broader antimicrobial spectrum, and azithromycin has still more broad antimicrobial spectrum. So that is another plus point, right? So that makes azithromycin more popular than erythromycin. Then side effects profile. Yes, side effects, gastrointestinal side effects. For example, I will not narrate and differentiate all side effects, but I will just touch the two. Number one, erythromycin, very common gastrointestinal side effects. But as compared to that, clarithromycin and azithromycin have far less gastrointestinal side effects or gastrointestinal irritability. And if we go for serious side effects, yes, now listen with your both ears. If you talk about serious side effects, erythromycin can produce side effects which act on the cardiac heart rhythm, long QT interval, and arrhythmias, can precipitate dangerous arrhythmias. But when you move from erythromycin to clarithromycin to azithromycin, the tendency to produce, yes, the tendency to produce dangerous cardiac side effect is also reduced. Dangerous cardiac side effects are also reduced. Then another thing which I would love to mention is drug-drug interaction. Erythromycin and clarithromycin, these two drugs are very notorious to produce drug-drug interaction, because erythromycin and clarithromycin, both of them affects the function of cytochrome P, right? In the special subset of cytochrome P, which also deals with many other drugs, right? So when you are taking these two drugs, erythromycin and clarithromycin, erythromycin or clarithromycin, and if you are taking some other drugs like lipid lowering drugs or some other drugs, or there's already some pathology in the liver, you should not take these drugs, right? Because if there's already some pathology in the liver, they can act as a hepatotoxic. They interfere with the function of the cytochrome P subsets, which lead to drug-drug interactions also. But when you come to the azithromycin, yes, the beautiful, the king macrolide, azithromycin, it has the minimal interaction with the cytochrome P450 subset, which also handles many other drugs. Due to that reason, azithromycin has minimal drug-drug interaction and especially minimal prolonged QT interval arrhythmia precipitating tendency, right? So these are few words that in a nutshell you should remember, that erythromycin, clarithromycin, azithromycin, roxithromycin, actually don't remember that mycin is in the end, keep in mind thro also, so remember they are thromycins, mycins, right? So mycins gone. But the important thing you need to remember, first drug was erythromycin, and now it is being less commonly used, and now most commonly used drug is azithromycin, which is derivative from the erythromycin. Why azithromycin is so popular? Because azithromycin has better pharmacokinetics, has better side effects, less side effects, and it is having broader spectrum of antimicrobial activity, and of course it is having, yes, less drug-drug interaction. In the end, I would say, don't forget, aminoglycosides and macrolides both work on ribosomal protein synthesis machinery in the bacteria, and both of them are concerned with the mechanism of action is to reduce the protein synthesis in susceptible bacteria, right? Here we can draw a simple picture like 30S unit, and here it is, yes, 50S unit, and this is 50S, and this is 30S unit. This is in bacteria. Actually, aminoglycosides attack at 30S unit. One way to remember is buy at 30. If you are a good businessman, buy at 30, at stand aminoglycoside and tetracyclines. So buy at 30 means that aminoglycosides mainly act on 30S subunit, and tetracyclines also mainly act on the 30S unit. And sell at, if you are bought at 30, if you're a good businessman, sell at, yes, 50. So 50S, that includes erythromycin, that includes, what is this? Chloramphenicol, C for chloramphenicol, E for erythromycin. This is for lincosamide, which is basically your clindamycin, and this is linezolid. So drug groups, what is this? C stands for chloramphenicol, act on 50S subunit. Erythromycin and associates act on 50S unit. Lincosamide, especially clindamycin, act on 50S subunit. And then we talk about linezolid. It's a new drug, and that's also act on 50S unit, right? But even though aminoglycoside also inhibit the protein synthesis in bacteria by acting at 30S unit, macrolide inhibit the protein synthesis in susceptible bacteria by acting at 50S subunit, but there is still big difference. You know what is that? That this drug, yes, this drug is bactericidal. It kills the bacteria by inhibiting protein synthesis. It means it inhibits the protein synthesis in a very aggressive way, right? That I will explain in the next lecture, upcoming lecture, that mechanism of action of aminoglycoside, because most of the protein synthesis inhibitors are bacteriostatic. But it is one of the exception which is bactericidal. Why it is so, that will be seen in next lecture. And macrolide, of course, they are bacteriostatic, right? Like most of the protein synthesis inhibitors, right? So that's all for today. Thank you very much. See you later.